It is a pleasure to be here. This is an extremely exciting project. I think what we're doing here is groundbreaking, and I think it is critical not only to improve how we deliver services to people in the territories, but to try to make sure that we can afford to continue to deliver those services.
We know from good research that's been conducted in Canada and elsewhere that some systems are predisposed to improvement and transformation.
And the more I learn about this project, the more exciting I find it to be.
We saw that this was a system that was predisposed to making improvements. They needed support in building capacity, and so that's where we started.
This process should be an evidence-based process. There's all kind of good reason for this, one of which is it's a prime determinant of success.
I think the original idea here was to find a way to train in a very short period of time a large critical mass of decision maker and practitioners in using evidence-based for problem solving and decision making.
So we have 10 people on our diabetes team. We have 6 in renal care.
The reality is we're a small jurisdiction, and our ability to do evidence-based analysis and program design and performance measurement is extremely limited.
So 2 issues, and the workshops are organized around addressing those 2 issues.
So anywhere we can tap into expertise and partnerships and get some help is just hugely important for us.
So the intent of that is to have a database that we can populate with all of our current renal clients, and we can add people in as they get newly referred into our system.
The idea came that maybe the best way would be to get practitioners and clinicians and managers to work in a participative process in actually solving a real issue, an issue that they were facing in their actual day-to-day practice.
My name is Ted Blondin. I live in Bechico, 110 kilometers out of Yellowknife on the shore of Marion Lake, and I'm a diabetic. There are no doctors in some of these small communities, and so if you have to see a doctor, you have to go to Yellowknife. And sometimes on really detailed work, I have to go to Edmonton for eye operations and that type of thing as my diabetes gets worse and affects the different parts of me.
About 50% of our population is Aboriginal, and the Aboriginal populations, whether they're Dene or Métis or Inuvialuktun or Inuit, have undergone fairly rapid social change and modernization in less than a century. So you've got a group of people whose lifestyles have changed substantially from people that were living on the land eating primarily a traditional diet. You've got people that are living in communities in much less physical activity associated with their lifestyle, much less healthy diet. Not only are they often not eating country foods, but they're eating highly processed foods because that's what they can afford. And there's a whole range of health issues associated with those changes, and I think this is a direct link to chronic disease, because what we see is obesity, we see a lot of type 2 diabetes, high levels of smoking, so we see a lot of chronic lung stuff. And so that's why this project is particularly relevant to the health status of the Aboriginal population.
We wanted to find a better way to deliver care, because very often we find it's not actually the quality of care that's the issue, it's how the care is organized that ends up being frustrating to the patient or the client and also to the healthcare provider. So that was probably the biggest factors, is seeing, how can we organize this better so that we do a better job.
This one?
Here. Some of the older people that have diabetes in this community, sometimes they're not even aware of it, and so what I'd like to see is more Aboriginal nurses so that they can communicate with some of the elders a lot better about some of the concerns.
We need to be working with the teams, the pilot teams, to be ensuring that there's good communication with
the people in the room really needed to be all part of this process. There's complex problems that they're trying to address around how do we provide the services that the people here in the territory need. And so you need that perspective from the frontline nurse, the family physician, the nurse practitioner, the folks at the dialysis unit, the physiotherapists, all of the professionals, as much as you need the folks who are responsible at an administrative level, the managers, the directors. So really what we were able to do was to get in one room people who are responsible for the delivery, the financing, the management of health services in the territory. And that's been absolutely critical.
With those specific conditions
there seems to become quickly a level of equality, if you want to use that word, to say that as much as we might be different hierarchies in the way we look at professions, we can all come to the table and share our thoughts, share our ideas, and all of those ideas and all those thoughts are valid.
The beauty of collaboration is that everyone can bring their perspective on, and no one has all pieces of information. So I think each of us has a role to bring their specific expertise in their field to aid in completing the puzzle of chronic disease and how we can improve it.
My name is Evelyn Blondin Forrest. I live in Yellowknife and I'm dealing with depression.
Here in the north, there's so many doctors coming in and out of Northwest Territories from the south, from Edmonton or Vancouver or Toronto, or new doctors are coming up here, and they don't really know the people here because of different language. There's Dogrib, North Slavey, South Slavey, Chippewan, and Cree, and so you got to look at interpreters, and the interpreters have to learn what depression is, and these interpreters need to know how to say these words.
Change management in healthcare is very challenging. It's complex. And one of the things in change that we do understand is that you need to have that vision. You need to have concrete evidence to create that urgency to move forward. And you need to have a solid core group that will be the champions to move the change forward and make it happen.
This is part of what the pilot kind of includes as well, though, is having the community people a part of the discharge planning.
It's been a fascinating process because it's unlike anything that we've ever done before in the Northwest Territories.
Only send in one report.
So getting people with involvement from people throughout the system, frontline providers, managers, senior leaders in the system, and starting with looking at really identifying what were the problems that we needed to solve and what was the evidence telling us about the best way to approach solutions to those problems.
One report to the community, and it's going to be something inside that community.
The hope for the project, at several levels. I mean, one hope is just the opportunity it's provided staff, not just in our department but in our system, to learn about evidence-based decision-making, to develop some skills in terms of designing a project and implementing and being able to track outcomes and then do some continuous improvement feedback.
My name is Larry Sangre. I'm from Yellowknife. I've been going through dialysis treatment for 17 and a half years. When I started dialysis, they sent me to Edmonton to dialyze in Edmonton because they don't have no dialysis unit in the hospital here in Yellowknife. So I've been there for 2 years, and then in '96 to open dialysis at the hospital, I came back, and ever since I've been here.
All-star forward, Jamie Benn had an appendectomy Sunday. Watch the Cowboys right hand, right there. That is a sucker punch. He Boucher said he punched him because he got...
By involving patients, by involving communities, you're actually starting to further the message, which is very, very important, that we have to look upstream. Prevention, patients being involved with self-management, and this type of chronic disease management strategy really puts it back onto community delivery in partnership with the patient and in partnership with communities. And really, that's what healthcare should be about. It's not about an acute system. It has to move to primary prevention and primary care.
Well, when you're diabetic, the best thing is to eat local traditional foods like fish and caribou meat and wild food. The exercise, you got to walk around a lot of times in these small communities. There are no taxi cabs, so the exercise is needed also.
I think the lessons learned both for the territories in how they do have to work together. This can't be left to one particular authority or one particular provider group, that you do have to have a vision and a plan for a full territory because patients move back and forth. That's very important to the rest of Canada. There's learnings in that, how to do that. But the innovation, the unique way that this was planned and attacked and developed, I think again fits with the discussions anyway right now in Canada on health system sustainability. Sustainability not just about money, but better patient outcomes, quality care, access. Certainly a piece of it is the sustainability financially.
What you guys did well was go right into sort of the indicators, right? So
and also to really take healthcare in Canada to that next level. This project doesn't answer all the needs, but it's certainly, I think, the experience both for CHSRF to now be able to use that knowledge with other jurisdictions, and the learnings within the NWT for other health areas that have that kind of a population or are sparse rural delivery. It's going to fit very nicely into the innovation strategy, and I think really needs to be looked at by others that are looking for innovation.